Okay, I'm going to send you live now.
Thanks, Lee. Good morning and welcome to this week's staff brief. I'm Paul Robinson, I'm the Chief Executive here at Sherwood, and with me today I've got Dave Selwyn, our Medical Director and Deputy Chief Executive, Maggie McManus, our Deputy Chief Operating Officer, and they're going to be discussing the Optimising the Patient Journey project. I've also got Ian Ferris joining. Ian's the Tobacco Dependency Service Team Leader, and Ian will be discussing updates around tobacco dependency on Nerve Centre. And before I move to you, Ian, I'll just pick up some general updates just to make people aware of. So firstly, we're changing the time and day of this team brief. So briefs in future from next week will take place on Tuesdays at 12 noon. So keep an eye out for further information coming through the bulletin and indeed the Facebook page on that. Our Freedom to Speak Up team have been nominated and shortlisted for Health Service Journal Awards. So they're a finalist in that awards with their project around growing our freedom to speak up culture. This project is to ensure that colleagues know they'll be supported when you do speak up, and understanding that speaking up and listening is part of the improvement, learning and providing outstanding care journey for all of us. As you're probably aware, we've got a full-time Freedom to Speak Up Guardian, that's Kerry Bosworth. We've got 20 champions, all being trained across the organisation, including for the very first time a medical champion. And we're doing more than ever to encourage a culture which is open to those conversations and ensure that each and every one of us have the confidence and support we need to speak up at an early stage. So congratulations to Kerry and the team for being a finalist there. More about awards, and that this time moving to our Excellence Awards here at Sherwood. There's 2 weeks of our nominations left to be open. If you know of any colleague, any team or volunteer that's gone above and beyond and you think should be nominated for an Excellence Award, then please do that. And the details on how you do that are in this week's bulletin. They're on the screensaver that you might see in the internal Facebook group, also on the intranet. Heatwave, here we go again with another heatwave this week. Thankfully, it's an amber warning, not a red one, than we had a few weeks ago, and that means that we're currently on alert level 3 across the organisation. There are many practical steps we can take to keep the heat out and the cool air in. So that includes keeping windows closed, keeping blinds drawn, keeping room doors closed wherever we can. Looking after ourselves, keeping ourselves and indeed others hydrated. So if you or you see someone who might start to feel unwell, move to a cool place, rehydrate and cool your body down as quickly as possible. And be aware of colleagues and of course patients who might be struggling in the heat. We've got a flexible uniform policy, and where it's appropriate, this can include wearing shorts, for example, instead of trousers, but please speak to your line manager about whether that affects you and how it affects you. So moving on, welcome to our new doctors in training. I think I mentioned this last week's brief. So we're delighted to welcome our latest intake of new doctors in training this month as part of the annual doctors changeover. So what's really good this year, we've got 216 of the 230 posts for doctors in training have actually been filled, which is a massive positive for the trust and any significant increase on previous years. And I'd just like to say thank you to everyone. You know, it's a lots of hard work from colleagues across the trust to onboard our new doctors, to induct and arrange payment for them each year. So thank you for that and for the support that you give to the doctors in training. And thank you for everyone who makes the changeover so successful. Pride, I probably mentioned last week, I thought Pride was over. I thought Pride month was done in July. However, there's a virtual Pride event across the Nottinghamshire Integrated Care System on the 10th of August. And this promises to be a great opportunity. So please tune in. This is an online event, celebrating Pride 2022 is a virtual thing for the ICS and can be accessed at nottinghamshirehealthcare.nhs.uk. Lastly, just want to mention that the pay award. So we've had some more details of how the pay award affects each of the agenda for change pay grades. We're going to publish that in the all staff bulletin tomorrow, so you'll see how it affects each grade. Just a reminder that there's a minimum of £1,400 per year uplift across all the grades, and the new pay rates will be paid, and the arrears backdating to the 1st of April will be paid in September pay packets. Okay, so I think that covers my general updates. Please advise us through the chat if you've got any questions or comments as we go, either for myself on any of those general updates or indeed for the people joining us. So on that note, Ian, I'll move to you, if I may. I'll reintroduce you. So Ian Ferris is our tobacco dependency service team leader, and you're going to hand over to you around how that affects Nerve Centre. Thanks, Ian.
Thank you very much, Paul. So yes, as introduced, my name is Ian Ferris and I'm the service lead for the tobacco dependency team at Sherwood Forest Hospitals. And I'm here just to give you an update on how our service operates, the changes we've made to Nerve Centre, why we've implemented those changes, and the steps that we're taking at SFH to ensure that we can help smokers go on from being an inpatient into services and quit. So just some local information and a bit of background. Smoking is still the biggest cause of preventable illness and premature death in the UK. Here in Nottinghamshire, we have a smoking population of around 95,000 people. And in Mansfield, we have a prevalence rate, which is one of the highest in the county, of around 23%, or roughly 1 in 4 people who smoke. Smoking across the county is costing the NHS around £40 million per year in treating smoking-related illnesses. So in 2008, I started as a stop smoking advisor, and I was really surprised then, and still surprises me now, that many smokers are still completely unaware that treatment exists within the community, that it's free of charge, and that it's easy to access. So we have many smokers who miss opportunities to access services because this information is not readily provided within primary and secondary care, unless, of course, a patient specifically requests support. So the tobacco dependency team act as a bridge between inpatient care and post-discharge support within the community. Our main sort of role objective is to provide support and information to patients at bedside, and to ensure that when someone is staying with us as an inpatient, they're comfortable and they're not craving too much for nicotine. With that, we also try and encourage some temporary abstinence while they're here, and hopefully continue that post-discharge into community services. So a lot of you, maybe most of you, will be aware that on the 6th of July this year, we added the smoking assessment to Nerve Centre, and obviously this should be completed for every patient on admission. The assessment does 2 main things. Firstly, once the assessment's been completed, whoever's been admitting that patient to ward will be given a prompt after the assessment to let them know what nicotine replacement therapy is available to the patient and what the recommended dose of that NRT would be. And we've obviously taken this step to ensure that when people come in, if they are craving nicotine, we can give them NRT on admission at the appropriate dose to try and alleviate any cravings that the patient may experience while in our care, and again, to encourage that temporary abstinence. As part of that assessment, once it's been completed, that then records the smoking status of the patient. So this means that my team can generate a list of admitted smokers on site, and our advisor can spend the day visiting those patients at bedside, provide support and information, also to make sure that the nicotine replacement therapy they're using, if they are using any, is being effective for them. We can also alter dosing if needed, and again, just to try and encourage that temporary abstinence to continue post-discharge with the community service provider. Now, I really can't state enough that without the Nerve Centre assessment, without smokers being identified to us, we would be in the dark. We would have no idea how many smokers we had on site, and we would have no idea where they are on site. So I would really like to take this opportunity to thank everyone that's completing the smoking assessment, and really just encourage everyone to continue doing as we are right now. It's vitally important for smokers and the tobacco dependency team that these assessments are completed, and to ensure that all smokers are given the right opportunities to be informed and engage with services. And just bear with me, I just need to pull up some numbers just to give you an idea of the difference this has made. Before the assessment was installed, we were identifying, and we had directly referred between 4 and 8 patients per day. We are now 20 plus per day. So we're hitting an average of around 400 per month. And I think last month we sent over 168 smokers to be referred into the local stop smoking services, which is absolutely amazing. So I'm sure you can understand the difference that this has made. And just while I've got your attention this morning, I will give you a really brief overview of what all the community services offer. So nearly all sessions are via telephone support. Some services do offer very limited face-to-face, but nearly all of them are telephone support. Nicotine replacement therapy and psychological support is provided free of charge for up to 12 weeks. And any nicotine replacement therapy that a client or a patient wants to use is sent to them in the post by the services, or they can collect from a local pharmacy. So as you can see, these services are incredibly easy for people to access. But we see people on a weekly basis, and when we tell them about the support available, the first question they asked is, how much is it going to cost? So it's really important that people understand that the support is available and that it's completely free of charge. And that being said, if any of you guys require any confidential advice or support, you can contact the team on extension 6066, or in fact, you can refer yourself to the community teams. You can also attend your initial consultation with the services within work time, which lasts around 30 minutes. Also, to finish, if anyone has any training needs or wants to know any more about the service, you can contact me again on 6066, or our details are on the intranet under smoking cessation. And thank you very much for your time.
Thanks, Ian. I've got a couple of questions or comments that have come in. Firstly, where can we get one of those cool smoke-free Sherwood Forest lanyards?
I've got about 7 left. and I inherited them, so I'm not really sure where they came from.
Okay, thank you. 7 left, so the first lucky people.
Yes, speak up.
So if you want one, then put that in the chat and we can sort that out.
Yeah.
So a comment from Vanessa Smith. We always ask our patients on Minster day case, should we be doing the nerve centre assessment for all day case patients?
You can do. Again, what we do is with any outpatients or any inpatients, if there's anyone that we're unable to speak to for any reason, they will be referred onto the services anyway. So yes, unless you're referring those patients directly to us via ICE or via the extension, then I would suggest that they get done on Nerve Centre also. That would be great.
Thank you. And lastly, is the service available for patients attending clinics as outpatients?
Absolutely.
Could you advise how we refer patients?
So you can refer via 6066. We have a confidential voicemail on there. If you I don't have any slides, so I can't show you our email addresses, unfortunately, but if you go on the smoking cessation page on the intranet, has our details on there. You can refer them by any of our .net addresses. That would be fine. All you need to do when you phone up or email us is just leave us the D number for the patient, and we'll pass them over to the community provider. Generally speaking, when the community providers receive a referral, they will be in touch within 48 hours, either by telephone or by text.
Ian, if you could just suggest what one of the email addresses is, then I'm sure Lee in the background can publish that in the chat.
Bear with me.
Be really helpful.
So it would be. So my email address is ian.ferris, that's FERRIS1 @nhs.net. We also have sue.barnfather, that's SU barnfather at nhs.net.
Great, thank you. So if Lee can pick that up. Dave, you wanted to come in and ask Ian a question or make a comment?
Well, yeah, I'll just make a comment. So obviously I said I wasn't going to say much on the call, but I couldn't help myself. So you can't take the medical director out of this. So just widening the focus a bit and maybe concentrating on those of our patients who are coming for operations. So we know that smokers have twice as many complications after an operation than non-smokers. So real value in doing this. And if you stop smoking before the operation, then you'll reduce your complication rate by 40%. And of course, everyone thinks, well, it's a chest and an infection, but actually it's not just those. It's also blood clots, it's wound healing, chronic pain as well is impacted by smoking as well. There's a whole national program that feeds into this that will support Ian's work, something called Stop Before the Op. But key bits, operations and coming to hospital, they're teachable moments. Let's make every contact count. Let's really make a focus on this. And it's not just about our patients, Ian. I just wondered how we can encourage all of our colleagues to also help with their difficult journey to give up smoking.
Certainly. So, like I said, there is confidential advice readily available on site or off site with the community services. We will provide as much support as we can on site. We will go to departments that people are working in. If people have got private locations they wish to speak to us about that, we'll provide consultation. It's not available yet, but there is a staff offer coming up, which is part of an app. I don't have the details yet, unfortunately, so hopefully when we do get those details, I'll be back on to share those. But that app will involve, obviously, an app on someone's smartphone, and they will also be able to get nicotine replacement therapy and vape devices from using that app. So that's really, that's a really good piece of work that's taking place right now. But like I said, we don't have the details of that as yet.
Yeah, thanks, Ian. And maybe we can invite you back when you have all that, and we can talk through how to download the app and its usefulness and functions, and how our colleagues can help themselves on what Dave describes as a difficult journey. So that's great. Thank you. Well, I think that's all for questions for you. Obviously, we'll pick any more that come up with you at the end, if that's okay.
Of course, yeah.
Yeah. Thanks, Ian. Okay, let's move on. So I'm introducing Dave, who you've just heard there, our Medical Director and Deputy Chief Exec, and Maggie McManus, who is Deputy Chief Operating Officer, but the last couple of months has stepped into the Chief Operating Officer role itself. So a huge thank you, Maggie, for that, and the hard work and commitment and certainly support you've given to me and your teams has been absolutely fantastic. So thank you for that. So I know you're here to talk about the Optimising Patient Journey project, but just wanted to make sure that recorded my thanks and the thanks of the executive team and board. And if you've got any reflections on that time, then certainly it would be great to hear them. If not, over to you on the patient journey project.
Thank you very much for that, Paul. It was certainly an interesting time because we had a fair few gaps within the leadership team in the organisation. So I think when I offered to step up, well, I was asked to step up and I accepted to step up. I didn't realise that we were going to be quite under the pressure that we were under, nor have a heat wave, nor have an incident. So I think next time anybody asks me, I might just be a little bit more careful about what my answer is. That said, though, I think it's a credit to this organisation that somebody is able to step up in such a safe space and be able to learn kind of on the job for such a senior post. And I just wanted to extend my thanks to everybody for being patient and kind. It was my first time doing it, and everybody was really patient and really helpful. Everybody that went the extra mile and the extraordinary time that we had. I saw some absolutely fantastic teamwork, and that is the epitome of Sherwood Forest, and I've said it a couple of times, and I did actually get a little bit tearful in one of the bed meetings when I just saw how everybody was working for each other, which actually makes these roles quite an awful lot easier. It's not even quite easy, an awful lot easier. And then obviously for all the support and guidance of the colleagues that worked most closely with me. I appreciate all of the time that you gave me and the learning that I got from you. So thank you very much, everybody. So, but now the reason that we're actually here. Myself and Dave, who we've already heard, the medical director, would like to talk to you about, and thank you for the opportunity to speak about, our exciting improvement programme, which is called Optimising the Patient Journey. As a lot of you will have experienced and as just referenced, in the recent weeks, our hospitals have seen some of their busiest times. COVID's still bringing people to the hospital and having an effect on our staffing. However, it's now more of the everyday ailments, injuries and illnesses that are bringing people to the hospital seeking our care. In the first quarter of this year, we saw more attendances to our ED than in any year since 2019, and we started recording attendances in the way that we do currently. This sustained pressure is being felt throughout the whole of the trust, so it's not just about the front door. And it led to a critical incident being declared in the days before Easter bank holiday, where we took extraordinary actions ourselves and asked system partners to support us in finding ways to reduce the pressure, especially in our emergency department, which was overcrowded. We've also had to take further extraordinary actions in the last couple of weeks, which saw us open even more beds on the Kings Mill site and take actions across our wards and departments that are over and above what we would do at times, what we would usually do at times of intense pressure. There are programmes of work across Nottingham and Nottinghamshire that are designed to reduce the current pressures and improve the pathway for patients who are medically fit and no longer need acute care, and also to keep patients from arriving at our front door. But some of these schemes need support and they need some time to embed. Therefore, our ability to actually move quickly with them is not as readily available as the things that we can do by ourselves. So within the divisions and the clinical leadership teams, and headed up by our medical director, we've co-developed an improvement programme, the aim of which is to make the patient journey through our services better. And if I could show you inverted commas, I mean inverted commas, better, because what does better mean for patients? What does better mean for our staff? We are going out to the organisation, to our patients, to understand what that truly means to them, so that we can make sure that any improvement that we are designing absolutely has them at the heart of everything that we do. We've called the programme Optimising the Patient Journey because that is exactly what we want to be able to do. And that's the journey from before the front door. So how are people actually getting to the hospital when they need to get to the hospital, up to the point at which they are ready to be discharged back to their own homes or their usual place of residence. The format of the programme is being facilitated by our wonderful QI team. So our quality improvement team are helping us to ensure that this is carried out in a structured way, that everybody knows what they're doing, and that we're able to pull it all together to get the best results. It's an 8-week programme, and it's focused on unblocking some of those things that we have tried to do in the past but have been too tricky for whatever reason, and that we've not been able to progress. So it's set out over 4 pillars. And they're the pre-hospital pillar, the ED and emergency care pillar, the ward pillar, and the discharge pillar. And the work has already started in the medicine division, who have picked up the pillars, taken them, converted them into their own speak, and are already embedding some of the programme. They have looked at it as a way of challenging themselves to address some of the more problematic issues that they have within the division, but also in consolidating some of the work that's already underway. There's a lot of improvement work that's happening in this organisation, and that is benefit to small numbers of patients in pockets of the practice that we deliver. However, once we bring it all together and make it into a full programme, our ability to optimise that increases, so that we can see something that will benefit then lots more patients without all of the individual work happening. Some of the areas that the medicine team are working with are around ward processes and how we can ensure that we have a consistency of approach that means that we are able to have positive action for patients every day. That means that they will be able to move through our system in a really well managed, consistent manner, regardless of which ward they're on. Engagement in the full multidisciplinary team to help with early discharge. So we all know that if everybody's involved at the beginning of a patient's journey, our ability then to move the patient to the point of discharge to the right place increases massively. And then how we manage cross-divisional issues and journeys that affect our patients. So at the moment, we have patients who move across our wards for legitimate reasons, and we want to be able to help them move in the best way and receive the same level of care across all of those wards. So that was a very brief introduction to the improvement programme. There is an ask of you in this. So everybody, regardless of whether you're clinical, operational, nursing, allied healthcare, estates, whoever, we ask you to be curious about the programme, be curious about optimising the patient journey and what it means to you. Think about what better means to you, better patient care, better patient journey, better staff experience. And think about what you can do and how you can get involved and how you can be the patient voice. And that is that. I'm happy to have any questions or comments.
Thanks, Maggie. So yeah, you sort of left us there with some very powerful things to think about. So be curious, and what does better mean to us all, really, as all as individuals and teams, and how can we support? So really interested to see any comments or thoughts coming through on that. And how do people get involved? Where are the touch points here for those teams that you've just asked that of? You know, maybe, you know, non-clinical and patient-facing teams. How will that connection be made?
So the way that the programme set out is we have 4 pillars and they have pillar leads. However, within your divisions, there will already be that kind of process setting up. So your divisional leadership team, your specialty leadership team, they will know about it. So they're the people in the first instance that are closest to you. Failing that, or in addition to that, I am here. Dave is here. I'm always happy to hear about what do you think about improvement in patient care, improvement in staff circumstances. So I'm always available for it. But once we have the pillar leads, we will be putting out more communication around the programme. We will have some videos about what better means to some of our staff and some of our patients, and some clear ways of how you can get involved, which will include telephone numbers, email addresses, etc.
Thank you. Thanks, Maggie. I haven't got any comments or queries coming in. So maybe just while we're waiting for those, I'll invite Dave to make a comment, not on the project and obviously its importance in keeping patients safe and keeping flow, but also, Dave, we've recently announced your appointment as Deputy Chief Executive. So I'm sure everyone's interested in what that means to you and to them and to the organisation. So I'll invite you to step forward now.
Thanks. Just going back to the project. So I don't think I've got anything significant to add to what Maggie said. I think I just reinforce the point. So it's really easy for us to get focused on well, actually we're okay, but it's someone else's problem. So those 24% of patients across the whole of the region who are in acute hospital beds, whose as Maggie described, whose care could be provided elsewhere. Actually, we are working on that, but that's a whole system approach, and that is very difficult, and everyone will be aware of that. But let's not get distracted by that, but focus on what we can do, what's within our grasp of things that we can do and change, and those internal actions or processes. And as Maggie says, it's around thinking about what we can do before the patient comes to a hospital, once the patient is in the emergency department, once they're on the ward, and then that discharge process. I think I would highlight that Maggie described it. This is a co-design. The idea of this is a co-design project with the clinical teams and the operational teams, and I think that's really important for it to be successful. I think what I would say is that the key of this is putting the patient at the centre of what we're trying to do, and I think we've got to be realistic here. So this is going to need some real focus and some real time and effort. So as Maggie described, we've engaged the help of our quality improvement, and there's a message in that title, the quality improvement team, as a change resource to help us with this. But actually, the other thing that we, in conversations with the divisions, we've recognised that particularly the clinical teams, the frontward facing clinical teams, they need a bit of headspace to be able to do this work, because everyone is so stretched at the moment. And so it's about just granting permission that this is really important to us. And as Maggie described, it's a rapid change process. It isn't a long drawn out, let's talk forever and go to lots of meetings. It's an 8-week snappy change. I like to think that what we're trying to do is we're trying to get ourselves fit for winter and do some of those actions as Maggie described that we've struggled with before. But we're not naive in this. We recognise that whilst that may be great, we do that in 8 weeks. It's going to be a continuous process, but going in we'll need to refresh and keep some focus on that. And then the only other thing I would say is that funnily enough, it's not just us who thought of that some internal process that we can do. There is a national directive program to help stimulate, and some of these are similar and some of them are a bit different, but there's a program called the 100-day challenge that's being launched that as an organization we have to pay mind to. So this program should address those actions for us. So that's the bit about the project. I think it's a particularly snappy title. I think that was my main role in the project to date. Maggie doesn't agree with me. So I might stop there, and then I'll pick up your challenge about what the deputy chief executive is, and hopefully it's not just that it means I'm getting old, but I'll come back to that in just slightly in a minute or two if there are any questions coming in.
No questions, Dave.
Okay. So the deputy chief executive. So I'm really pleased with this, really proud of this. It's a real honour for me. Thank you. But it obviously is a role that will hopefully complement your role as the chief executive, and will support you. So, but not just in the deputising sort of aspects. I think there is other ways that this will significantly help Sherwood. I think it's important that as the integrated care boards, the integrated care system kicks off as a fully functioning statutory body, and we navigate our way through that as an acute trust, it's important to have different voices in those forums, and that's really what I will bring to that system, a different voice. Possibly, and you can reflect on this, Paul, I have a skill or an irritation that sometimes I ask the difficult questions, and sometimes I continue to ask the difficult questions, and us as systems, we've perhaps talked about that in terms of a project. It's easy not to do the difficult things, but I think as this system develops and as we take forward what healthcare is going to look across Nottingham and Nottinghamshire, then it's important to have those difficult questions perhaps being challenged. And then of course there is going to be a need to change how we provide healthcare, and some of that will be around how our services look and feel and function. And so I would think heavily involved in that review, that redesign. And of course I come with certain links into other organisations, be that the City Care, be that NUH, be that the Healthcare Trust, be that into Bassett Law. So I hope I'll bring that. I think there is specific aspects that I'm interested in, and that's around actually how do we allow organisations to innovate in this pressure cooker of the world that we're currently operating in, because actually that's the only way that we are going to make progress. We can't keep doing things the same way. So I have some ideas and some plans for that. And of course I'm really delighted to have been asked to provide the guest blog for this week, and whilst it's still embargoed, I do understand that the current feedback is that it's the greatest blog of all of the guest editors that you've had in the last couple of months, but we'll perhaps allow that to come out.
Thanks, Dave. Yes, so delighted that you're stepping into the deputy role, and just to make clear that this is a dual role with your medical director responsibility. This is an add-on that you're picking up. I'm incredibly grateful for you doing that. I'll be looking forward to working you, and I think it's absolutely key that we get a strong clinical voice at those senior leadership forums across the ICS and indeed internally. So I look forward to that, and I look forward to more of your modesty as well. Okay. So no questions or comments. I think just wrapping up on the project itself. My aspiration is that sort of building upon that fit for winter comment that you made there, Dave, is that we approach winter in our planning as a whole organisation, that we have a demand and capacity plan, and we have a whole hospital and trust response to delivering a safe winter for patients. This is the major component of that, but it's really important that we have a whole trust approach, so that each and every one of our members of our teams, patient facing or non-patient facing, understand what support and role they play in delivering safe patient care this winter. So I really look forward to this project and how it can improve our processes and ultimately the patient experience. Okay, so still have no questions. I've got a comment pulling my leg over a 20th century phrase that I used about pay packets. So apologies for that. That's very 1970s, 1980s of me. So for those that need a translation, you will be paid the new pay award pay rates and arrears in your September what's the word? In your September salary payment and in your digital remittance advice, not in a brown paper pay packet. So apologies for that. I'll try and remember it's the 21st century in future. Okay, still no comments, sarcastic or otherwise. So I'll wrap up. Thank you to Ian, to Maggie and to Dave. Thank you for joining us. Please keep cool in the heat that's coming up. Take care of yourself, your colleagues, and of course our patients. And just a final reminder that from next week, this brief will be on Tuesday at 12 midday. So until then, thanks everyone for joining, and take care of yourselves. Bye.
Thanks everyone.
Thank you.